I really want to thank the Ogden Surgical Society for inviting me back to speak this morning. Of all the things in rheumatology over the last 2 years that have kept me from sleeping, it's COVID, and I think that's been your experience as well. I don't have to remind this group how we all felt 2 years ago as COVID hit the community, and we wondered how it would affect our patients, especially for somebody like me who suppresses immune systems for a living. I was really concerned about our patients. Early on, we didn't have a lot of guidance about what to do for these patients, and so it was quite unsettling. Now we have some more information, and I'm hitting the green button. There we go. Before I get started, I wanted to let you know I don't have any disclosures. Looks like I'm going to have to be slow on the button here, so no disclosures this morning. Objectives for today. I do want to talk specifically about the effects of COVID-19 on rheumatology patients specifically over the last 2 years, what I've seen in my practice and how this has been associated with what's been published in the literature. I want to discuss the effects and efficacy of COVID-19 immunizations in our immunosuppressed patients. It's something important for all of us to understand. And I'll finish up this morning with CDC immunization guidelines for COVID-19 vaccination in our immunosuppressed patients. When this all started, as I mentioned, this was very disconcerting for us. We didn't have a lot of guidance from the American College of Rheumatology about what to do. And I think most of us felt this unsettling feeling. Later on, the American College of Rheumatology finally came out with some guidelines for us that helped us know what to do, but this is concerning. When this first started, we knew that there were some risk factors for COVID-19 patients, those that were not rheumatology patients necessarily, but we didn't know exactly what to watch for people that had rheumatologic disease and were immunosuppressed. And so finally, some of the guidance came out, which included age, older individuals, which is not a surprise. Male gender was one of those things. Chronic diseases like chronic lung disease and cardiovascular disease. And then, of course, as you look here, corticosteroid treatment was one of the risk factors, which wasn't a surprise. And then important to this conversation today is the fact that they started to note that there were some other risk factors, including the fact that when patients receive medications like rituximab, which you remember is an anti-CD20 monoclonal antibody that knocks out B cells for an entire 6 to 9 months or so, that was one of the concerns, as well as other immunosuppressives. Some of the other studies that started coming out showed that patients that were infected with COVID-19 had a mortality rate of about 1.3%, and this is early. Some of these studies were quite early, and the data that we have wasn't very good. Some of the studies were small. But again, I want to highlight the fact that one of the things they saw here is that rituximab and treatment with other medicines like mycophenolate, which affect B cells, significantly increase their risk for COVID hospitalization and even death. Here's a study that was done in 2021 that showed out of about 90 patients. Now this is a retrospective chart review, so it wasn't a great study. In fact, this one showed that there wasn't a lot of concern for COVID patients that were immunosuppressed. But again, at the bottom you'll see that rituximab was associated with increased risk of cardiovascular of COVID-19 death. And then at the bottom there, you'll see that vaccine immunogenicity was negatively associated with older age, rituximab use, and mycophenolate use. And so what we notice here is that not only do patients have an increased risk of hospitalization and death from COVID-19 when they are immunosuppressed with rituximab, but we notice that they didn't respond to the vaccines either. Later on, a larger VA study came out, and these are in rheumatology patients with rheumatoid arthritis, that showed that there was a significant risk of death with COVID-19 patients and hospitalization. And again, you'll see that the risks down at the bottom were DMARD use, or disease-modifying anti-rheumatic drug use, chronic conditions, Hispanic race, black race, specific to this study, and the presence of chronic conditions. This is an interesting case. Now, these are things that started coming in before we had a lot of information. This is a 65-year-old lady who had rheumatoid arthritis who was on an IL-6 inhibitor, tocilizumab. She had unfortunately contracted COVID-19, and 2 weeks later said that she was in the grocery store and had sudden severe pain in her foot. By the time she got home, her foot was so swollen she had to cut her shoe off. Unfortunately, she waited about 2 months before she came to see me, and this is what I saw as I pulled off her sock. So she had COVID-19. 2 weeks later, she developed an arterial clot to the lower extremities and unfortunately had to undergo a below-the-knee amputation on that side. Over the course of the last 2 years, we've seen that COVID-19 significantly increases the risk for systemic flares of lupus. We've seen rheumatoid arthritis patients with flares of their RA. We've seen new cases of IgG4-related disease in relation to COVID-19. We've seen COVID toes mimicking vasculitis. And we've seen new cases of microscopic polyangiitis, which is one of the big three ANCA-associated vasculitides. This particular young man, in his mid-20s, developed COVID-19 and shortly thereafter developed a rash over the knees and these mottled lesions over the toes, and he was sent to me to rule out vasculitis. As I looked at him, I noticed with his history of COVID and no serological or clinical indicators of vasculitis that he had what we call COVID toes or pernio related to toes. What's interesting about this case is his symptoms got a lot better over the course of 2 to 3 weeks, but then he was vaccinated against COVID-19 and had the symptoms all flare back up again. When I saw him, his symptoms were already on the way out again. Some of the rheumatologic manifestations that we've seen that are reported in the literature include different types of musculoskeletal manifestations, arthralgias, PMR-type symptoms. I mentioned the COVID toes, urticarial and other rashes, Kawasaki's disease, and other autoimmune diseases that we think are probably triggered from COVID-19 or from the vaccine as toll-like receptors activate interferons and begin this inflammatory process. With the COVID toes, it's a vasculopathy, and many of you are well aware of the vasculopathy that we see with COVID-19, and so vasculitis-type symptoms are very common, including limb gangrene with necrosis. I showed you a picture of that. Temporal artery concerns for giant cell arteritis, myalgia, purpura, arthritis, and so on. Other studies that have come out have helped us to sort of characterize how COVID-19 vaccines can affect people. The things that you see there that are listed as primary features on the left are statistically significant. The others are just features that they noted. That includes oligo or polyarticular arthritis, PMR-type symptoms, tenosynovitis, and enthesitis. So these are things that you might see in your clinic still as people come in with long COVID symptoms and what appear to be rheumatologic manifestations. Those people were, in this study, treated mostly with glucocorticoids. Some people had to be treated as the symptoms were prolonged up to 6 weeks with disease-modifying anti-rheumatic drugs. Most of the people were able to recover within about 2 weeks of their COVID diagnosis, but there are people who were out 6 weeks. And I can tell you from my own personal experience in the clinic that I have people there that have been there for months with inflammatory arthritis, and we're not sure whether to tell them it's a new case of rheumatoid arthritis or whether or not it's long COVID symptoms and will eventually resolve. Again, if you look in the literature, giant cell arteritis, leukocytoclastic vasculitis, flare of Still's disease have all been reported with both disease, COVID-19 infections, as well as vaccinations. So what can we say about the efficacy of the vaccinations in people that are immunosuppressed? There have been some large studies that have been published, fortunately, to help us understand this. You can see we're looking at, for instance, this one with 97,000 patients that were vaccinated versus 42,000 that were not vaccinated. You can see that taking immunosuppressants increases the risk of COVID infection, and the Pfizer and Moderna vaccines were highly effective in reducing the risk of COVID-19. The Johnson & Johnson vaccine wasn't as effective, but in this study they felt like it was because the numbers were small. What I want to highlight with this slide is that boosters make a difference, especially in rheumatology patients and immunosuppressed patients. And what they've found over time is oftentimes the response to the vaccines in immunosuppressed patients are sluggish, but within 3 doses or 4 doses, you find that they actually do respond to the vaccines. Here's a large meta-analysis where they looked at 82 different studies, and they looked at the different vaccines. Now, this was worldwide studies, so it wasn't just the 3 that are FDA approved here, or were FDA approved here, but also these are the other vaccines that were used throughout the world. What they found is that patients with hematologic and solid organ cancers and rheumatologic disease were half as likely as normal people to seroconvert after their first vaccine. This improved with second and third vaccine doses. Interestingly enough, those that have organ transplants were 16 times less likely to seroconvert after the first vaccine, meaning again that they do not seroconvert very commonly with that first vaccine. It was sluggish with the second dose, and then usually the third or fourth dose, they would respond to the vaccine. I want to highlight the effects of, again, B-cell depletion. So I mentioned a few minutes ago the effect of rituximab and anything else that depletes B cells. This has been a significant issue for me because I realized early on the potential mortality in my patients on rituximab. This was very frightening to me. My personal experience is that mortality rate is higher in patients that are B-cell depleted, and they quite frankly don't make an immune response to the vaccines. Here's a study that was done, finally published in January 2022. So realize this was just a few months ago. This has been very difficult because the information has been slow in coming, and so we've been trying to do the best we could to manage these patients without a lot of information. But finally we have some information here that will help us. This particular study looked at B-cell and T-cell responses in patients with B-cell depletion. And what they found in 30 patients, 30 out of 30 normal controls responded to the vaccine, but 0 of the patients receiving rituximab responded to the vaccine. After COVID infection, both normal people and those that are on rituximab did respond. So what's interesting about this is that if patients get the vaccine that are on rituximab, they don't tend to respond well, but if they get the disease and they're fortunate enough to recover, then they're able to develop a better immune response than the vaccine itself. This study shows what's intuitive with this. If you are able to give the people enough time, your patients enough time to recover, to let their B cells recover, you get a better immune response. So for instance, what they saw here is that if you dose your rituximab every 6 months, which is a standard dose, only about 14% will respond to the vaccine. But if you wait for 6 to 12 months, about 45% will respond. And at 12 months, you get a better response, about 87%. And so what this has pushed us into doing is having to make some difficult decisions with our patients very individually. In some of my patients, we've had to switch them from rituximab treatment to another therapy, which is a big deal because most of my patients that are on rituximab for their rheumatoid arthritis or for their vasculitis have tried several other treatments and nothing else works. And so this is a huge conversation for us to try and decide what else to put them on that may not work as well. The other option is to delay the rituximab and cross our fingers and hope for the best that they do well enough that we can maybe get them past that 6-month mark and maybe even to the 12-month mark and get them vaccinated with a vaccine that will hopefully provide them some protection. I do have patients who have to have their drug every 6 months. If they don't, they flare. And so we've been getting them set up with a new FDA-approved by emergency approval tixagevimab and silgavimab, or Evusheld is the name of this monoclonal antibody. These are immunoglobulins to COVID-19 that they can receive as an injection, 2 injections And we're thinking we're going to give these every 6 months. But again, this is a moving target for us. And so for those people who need the rituximab, we're getting them the Evusheld. So for the sake of this conversation, it's important to understand who is severely or moderately immunosuppressed, because this will be important for our discussion for vaccine guidance and vaccine recommendations. So anyone receiving active cancer treatment for tumors or hematologic malignancy would be immunosuppressed, as well as those that are receiving organ transplants and are taking immunosuppressants. Those receiving stem cell transplants within the last 2 years, or those taking immunosuppressants. Anyone who is moderate or severely immunodeficient because of a primary immunodeficiency, advanced HIV or untreated HIV, and any active treatment with a high-dose corticosteroid or other drugs that can suppress the immune response. These folks are moderately to severely immunosuppressed. The American College of Rheumatology finally came out with some guidelines and some consensus statements about how to treat these patients, and I think this helps as we start wrapping up this conversation to serve as sort of a conclusion for some thoughts this morning. At the end of the day, the healthcare provider is the one that's responsible for engaging with the rheumatology patient in that discussion about how to vaccinate and when to vaccinate in the setting of immunosuppressants that can, quite frankly, risk their lives. Rheumatology patients are at higher risk to be hospitalized with COVID-19 and worse outcomes compared to the general population. Rheumatology patients should be prioritized for vaccination before the non-prioritized general population of a similar age and gender. And this is an important point to make, and I'm sure you all hear this as you talk to your patients every single day, and they bring you their information about what their friends said or what the internet says about the risks of COVID-19 vaccination. Beyond allergy to any of the vaccine components, there are no known contraindications to being vaccinated against COVID-19. The response to COVID-19 vaccination for rheumatology patients is going to be blunted, and you have to expect that. And again, we want to highlight the importance of getting these people boosters on time. Importantly, the risk of rheumatology flare that we talked about, the fact that you can have these immune-mediated flares from either the vaccine or from the disease itself is not a reason to keep someone from getting a vaccine. So here are the updated CDC guidelines for recommendations. This is something you have to watch almost weekly because they're changing regularly. But you'll see for the Pfizer vaccine, age 12 and above, for immunosuppressed patients, the initial treatment is not 2 primary doses, but 3. 3 primary doses. The first and second doses separated by 3 weeks, and the second and third separated by 4 weeks. And then very importantly, 3 months later, a 4th dose. So this may surprise you because this seems like a lot, but realize that our immunosuppressed patients, by now, at this time, some of them could be on a 5th dose, which I think surprises a lot of people. For the Moderna vaccine, 18 and older, they also get 3 primary doses separated by 4 weeks. The 4th dose, 3 months later, and then a 5th optional dose, 4 months after that. So, of course, the question comes up, what about the J&J vaccine? Can't get it anymore. It's not really being used. But what do you do about those people that started with the COVID or with the J&J vaccine? So again, they need to be 18 years of age or older. The primary series should be the first dose of a Johnson & Johnson and then a second dose of the Pfizer or the Moderna vaccines given 4 weeks after the first dose. As far as a booster after that, another Pfizer or Moderna given 2 months after the second dose. And then for moderately or severely immunosuppressed patients, they can choose to receive a second booster or the 4th dose of one of the mRNA vaccines at least 4 months after their first booster. So, in conclusion, COVID-19 has been a significant challenge for rheumatologists and for those of you who treat immunosuppressed patients because they are at risk, and they're still at risk. COVID-19 vaccines are effective at reducing the risk of severe infections and hospitalization, but vaccine responses are blunted in the immunosuppressed, and that requires COVID-19 boosters on time. Treatment with B-cell depletion increases the likelihood for severe COVID-19 infection requiring additional interventions. Waiting for B-cell repletion prior to a COVID booster enhances the likelihood of seroconversion. COVID-19 infection and vaccination both can flare rheumatologic diseases in a variety of ways, but these flares are usually self-limited. And although information about the effect of COVID-19 vaccines and immunizations was initially sparse, it's now being published plentifully, and you can notice in journals that are coming out weekly new information about COVID-19, its effects, and the vaccinations and their efficacy. Importantly, patients on immunosuppressive therapy should be on their 4th or 5th COVID vaccines by now. And I'd like to thank you for your attention today, and I'll open up the floor for any questions you might have.
Hello. So you addressed it somewhat, but if you have a patient that has had a booster and a significant flare from that booster, it's now time for the next booster. Are we still recommending that booster as well?
So that's a very good question, and I'm not always certain how to answer that. That question comes up regularly with my patients. I think it depends on the severity of their response to that COVID booster. I think if they had a mild flare of symptoms, I would continue to give them the booster. If you have somebody who had something near to an allergic response, I probably would hold off on that. But if you're talking about rheumatology flares or flares of their immune system that might include arthritis or might include increased fatigue or whatever else it might be, I probably would recommend that next booster.